Dr. Moreno, thank you very much indeed for asking me to join you and welcoming me to your session. You've kindly asked me to speak on the subject of underactive bladder, and of course, on the other side of the coin is detrusor overactivity. We need to think about the evaluation and treatment of this important condition. These are my disclosures based on my long-standing interest in pharmacology, following on from my doctorate in pharmacology. The most important thing to realize is that lower tract symptoms are quite diverse, and I think as urologists, we all appreciate this. But we mustn't forget that the bladder is an unreliable witness. Symptoms are not disease-specific. Patients find them quite difficult to explain. They may be embarrassed. There may be problems with misunderstanding the implications of these conditions and lack of knowledge and low expectations of treatment. And as urologists, we bring our own knowledge and interpretation to the way in which we analyze the symptoms patients present with. Ultimately, if you look at the pathophysiology of the lower urinary tract, you can have overactivity, you can have reduced contractility of the bladder or underactivity, and you can have bladder outlet obstruction. And of course, behind all that, we have a number of different causes. Ultimately, we often don't know the cause. It may be idiopathic. There may be a functional abnormality, Fowler syndrome, dysfunctional voiding. There could be a problem with the muscle. There could be drugs, such as opiates, inhibiting bladder contraction. There could be damage to the nerves after radical surgery, after pelvic fracture, for instance. Or, of course, the neurological conditions that we all know, vascular, degenerative, peripheral neuropathies, and of course, spinal injury and so on. And you can see that highlighted as I go through each of them there. The next question is, can you actually produce drugs by using animal models? And I'm afraid the bad news is that no drugs have ever come out of animal models being predictive. And we've got many diabetic models, obstructive models, ischemic models, irritative models, aging models. The next question is terminology. When we use a word, we should know what it means, and you should choose it to mean what you mean it to mean. And in this context, of course, we have many different terms that are used in English, and I'm sure it's very much the same in Spain. Looking at Spanish, looking at the different terms. In Mexico, for instance, you may have somebody talking about detrusor areflexia, atonic bladder. You may talk about desensate bladder, chronic retention, detrusor underactivity, which is the preferred term by the ICS. And this is a urodynamic diagnosis. But what about underactive bladder, which is the other side of the coin to overactive bladder? So if we actually look at this, and this is just data looking at urodynamics, you can see in men on the left, women on the right, and you can see that if you look at storage, voiding, and post-micturition symptoms, there's similarity between patients who have detrusor underactivity and no detrusor underactivity. So you've got a dilemma. If you're actually looking at symptoms, they're not very predictive. With that in mind, I set up a working party at the International Continence Society, which came up with this definition, which was the underactive bladder is characterized by a low urinary stream, which is slow, hesitancy, and straining to void, with or without a feeling of incomplete bladder emptying and dribbling, often with storage symptoms. Because if you leave behind a large residual, of course, the bladder doesn't empty, and you can often get storage symptoms. And one has to consider gender, age, neurological status, and of course, the other associated investigations which are used. To take this further forward, one of course needs qualitative and quantitative research. In the time available, I can't go into that in more detail, but we know as urologists what normal detrusor function is, which is achieved by a volitional initiation of contraction that leads to complete bladder emptying in a normal time span and in the absence of obstruction. And for a given detrusor contraction, the magnitude of the recorded pressure rise will depend on the degree of outlet resistance. And here you can see a patient who has, I'm sure you'd agree, detrusor underactivity with a low pressure, low flow. But of course, in this case, we don't know what the contraction strength is, the contraction duration, and the bladder emptying time. There's no doubt about this patient. You can see there's absolutely no detrusor contraction, a so-called acontractile bladder. But this patient could have bashful voiding, volitional inhibition. And is it therapeutically relevant to differentiate between detrusor underactivity and acontractile bladders where there's no contraction at all? Let's fall back onto urodynamics. Derek Griffiths in 1972 was working with Turner Warwick at the Middlesex Hospital, and that's where urodynamics first started. And he mentioned the detrusor pressure flow relationship, the hysteresis loop. And that, of course, you know from the ICS terminology, where you've got underactive, which is low pressure, low flow, whereas normal is high flow, low pressure. Obstruction is slow flow, high pressure. So, of course, we have the Abrams-Griffiths normogram based on the work of Griffiths, and I'm sure you're all familiar with that. And from that, you can derive various characteristics. With good quality urodynamics, you can derive the Watts factor, which estimates the power per unit area of bladder surface that is generated by the detrusor. There's a long calculation for this, and I can't justify this. It's a physics equation, but certainly it gives you the Watts factor, which allows you to look at the detrusor function strength. It's a minimally dependent on volume, but it's limited by being a complex calculation, and there's no validated cutoff points. But nevertheless, you can see on here how that maps with the low pressure, low flow situation. Taking this further forward, one can look at the PIP, which is the projected isovolumetric pressure, which you do during a stop test during urodynamics. And you can see that you can use this as well to differentiate between a weak and a strong detrusor. This is simple to use. It's measurement which is easy to obtain during a stop test during urodynamics, but it has the limitations of not being applicable to other groups, e.g. men with post-prostatectomy incontinence, and it's got a poorer retest reliability than a stop test alone. But nevertheless, you can look at the bladder contractility index, which gives you these parameters, which help differentiate between a strong and a weak bladder. What about ultrasound? There's been work on this, but I have to say that you're dealing in millimeters, and really it depends on the bladder volume, and I don't think it's very accurate, I'm afraid, even though you can see in this study they tried to look at it in great detail. What about other ways of looking at voiding function? Of course, you've got the occlusive test where you can squeeze the penis with a cuff, but the problem here, of course, it's got the limitations of being impractical. Of course, you can't use it to women. With women, it may be painful, and it may be difficult in some patients who can't tolerate it. It can underestimate the contraction strength because, of course, you're using a cuff and there's variable compression, and you need to repeat the voiding phase because, of course, it's a continuous occlusion. But it has the advantage of being a real-time indication of the isovolumetric strength, and there's good retest reliability in many patients with no calculation. But in real-life practice, you can't do urodynamics. You have to use various other approaches. The symptoms, I've mentioned already the unreliability of those, free flow rates, post-voiding residuals, and of course, patients in retention or chronic retention. It's fairly straightforward. Now, if you look at the world literature, there's been various attempts to look at underactivity using symptoms, but across the board, if you boil that down, detrusor underactivity affects between 9 to 28% of men under the age of 50, and 48% of those over 70 years have undergoing urodynamics have underactivity. The truth of underactivity is found in 12 to 45% of women undergoing urodynamics and is more prevalent amongst the institutionalized elderly. So you can see here that this is the gist of it. So if you want to use the term BPH, beware in men as they're getting older, because they may not just have obstruction, they may have underactivity. And so there is a potential use for urodynamics, particularly with very large residuals. What about interventions? Well, obviously there are a number of different approaches. Of course, you can put in a catheter to circumvent the situation. You can deal with outlet obstruction by pharmacology or by various operative procedures, or you can use pharmacotherapy, possibly to increase the bladder contraction. And at the end of the day, you can also stimulate the bladder and do other things to it. Doing nothing is very reasonable. And of course, I've already mentioned physiotherapy can be used to help, and catheterization. Doing nothing, you can see here from a study from the United Kingdom in 2005, where they just followed up men with large residuals, with low pressure systems. And you can see they followed up for mean follow-up of 13.5 years, and you're talking about residuals of 300 to 400 mils. And only 11% of the patients, due to worsening symptoms, actually required intervention, and only 4%, 3 patients out of the group, actually required acute intervention for acute retention. What about monitoring? Of course, if you do that, you have to follow the residuals, look at the biochemistry, look at the upper tracts if you're worried, with regular ultrasound. Catheterization, none of our patients like this, but very clearly that's a way of draining the bladder. Of course, clean intermittent self-catheterization is the best for the patient rather than indwelling catheter. I'm afraid there is no drug therapy, either at the bladder or the bladder outlet, which has proved particularly effective with the underactive bladder. If you talk about parasympathetic agents, they're not recommended for use because of the side effects, and none of these other therapies have really been shown to be very effective. If you look at this, what about the future? This is a recent review, and the conclusion was we've looked at all of the pharmacological approaches, and there's nothing that looks particularly attractive. Electrical stimulation, well, you can stimulate the bladder, you can stimulate the sacral spinous cord or the spinal cord, but to be honest, in the non-neuropaths, there is no evidence it's effective at the present. Sacral neuromodulation, slightly different. There is some evidence, but you need to have a contracting bladder for it to work, and it doesn't work in everybody. So you're talking about maybe with a reasonable contraction, even though the bladder is underactive, maybe 30–40% efficacy. So if you look across the board, and you can see this is a study looking at urodynamically defined patients and treatment, the majority managed by intermittent self-catheterization. You can see observation alone in a quarter, 10% you can see intermittent catheterization, and then sacral neuromodulation, and then really sacral neuromodulation alone in a proportion. So even with sacral neuromodulation, you may still need to catheterize. Now, we're surgeons. Of course, you can reduce the outlet resistance by transurethral resection of the prostate, but if you've got a very underactive bladder, it won't work very well. Botulinum toxin, I'm afraid, only works for about 30 days if you look at the literature, so not recommended for use, no control trials. Reduction cystoplasty doesn't work. Stem cells, injecting them in the bladder, really no evidence at present, I'm afraid. But there is interesting work with doing something to the bladder itself. But there has been discussion about putting in nerve grafts. I'm afraid that's been disproven. There is, however, the body of work looking at doing something to the detrusor. My colleague at the AU, you saw on the second slide, on a stencil developed this technique, and there was a multi-center study showing the efficacy of this approach. And certainly what you can do is take the latissimus dorsi, and you can wrap it around the bladder and use it to contract the bladder. But you're talking about an 8-hour operation with 3 surgical teams, and there's a very limited group of patients it's appropriate for. I hope you will join us at the EAU meeting, the virtual meeting. I can tell you it's going to be a very dynamic program, just the same as any EAU meeting, with all the latest developments in the field, with highlights, debates, evidence base, abstracts, and the section meetings, as well as live surgery. So we look forward to seeing you at the meeting. And well done on your beautiful program for your meeting. And I hope and know it will be very successful. Thank you for your attention.